Ever wonder how a 56-year-old physio like me deals with his OA aching knees? Well, put on your blue physio shirt, my young friend, because we're going on an OA physio knee adventure. But don't worry, I'm not going to bore you with long-winded lectures about knee anatomy or the pathophysiology of osteoarthritis. I need to give you an overview of what I'm doing so you can go to the clinic tomorrow and apply these ideas to your own patients. I've thrived in physio for more than 30 years doing mostly clinic work, but also nursing home and inpatient setting. And my biggest piece of advice to young physios is that you got to be organized, have a plan. So as my knees started to ache, I put aside my macho fitness gym exercises and went back to my physio programming. If you've seen some of my other videos, you know I've crafted and honed my Simplified Physio approach over the years. This is a system based on the 3 diagnostic categories and 3 treatment stages. The 3 diagnostic categories are overuse, traumatic, and systemic. This simplifies your physio diagnosis and clarifies communication. The 3 treatment stages are pain management, recovery of motion, and strength, balance, and mobility. This helps organize your patient's treatment and makes it easier for your patients and your team to understand what to focus on. This simplified approach to physio diagnosis and treatment provides a simple, practical framework for organizing your patient care and making decisions about treatment. It is a workable, adaptable approach that I've used across different physio settings. So today we're talking about knee osteoarthritis, which is a systemic condition. What does that really mean for our patients in our approach to treatment? Unlike a sprained ankle or a pulled muscle, OA isn't a quick fix. These patients are in for the long haul, so we need a realistic plan. In our role as physios, our best approach is to empower our patients. This means educating them about their condition, teaching them self-management techniques, and helping them set sensible goals. We need to be honest with them about the chronic nature of osteoarthritis, but also reassure them that they can live active, fulfilling lives. A key part of our physiotherapy is creating personalized home exercise programs. These programs should focus on addressing range of motion loss, useful stability, and functional abilities. And everyone needs fall prevention. We can also recommend assistive devices like canes, crutches, or walkers to reduce stress on the joints and improve safety. Remember, it's not just about treating the knee. We need to consider the whole person and put that whole person into their life situation. And wow, does the internet have a lot of options for knee arthritis. It's like trying to find a needle in a haystack of cat videos and dance challenges. I know there are a million YouTube videos out there, and everyone's got their own flex on knee arthritis. While some of these ideas have merit, it's important to be critical and evaluate them and apply them judiciously. You need a system, and you're in luck. I have a system. For example, I just had a patient raving about knees over toes guys on YouTube. How do I compete against a richer, buffer competitor? He's got a slick product going, and I bet you he sells tons of products. While some people swear by his program, we need a broader context to rehab our knee patients. He does a great job emphasizing gentle exercise progressions. Great, no problem with that. And I'm sure a little bit of knees over toe movement isn't the end of the world, but forcing it can lead to unnecessary pain and suffering. Similarly, while exercises like tibialis anterior raises are beneficial, they're just one piece of a well-rounded, balanced exercise program. We need more exercises to focus on ankle, knee, hip, core stability in their balance program. So it's not just about sleds and walking backwards. You need an all-encompassing approach to take your patients from pain to recovery of motion to strength, balance, and mobility. That's why I'm here. We're going to go through it all. And I know there's more to life than physio. No, wait, it's true. And that's my bonus feature today, the non-physio things you got to consider when it comes to knee arthritis. But first, let's consider pain management. Section 1, Taming the Beast, pain management for osteoarthritis of the knee, education, modalities, exercise. Pain management for the OA knee has 3 sides: education, passive modalities, and pain-free exercises. Education empowers the patient to take care of themselves. Ice, using ice for 10-15 minutes at a time, several times a day to reduce the pain and inflammation. I know there is some research against ice for acute injuries. So instead of the old PRICE protocol for acute soft tissue injuries, there are the newer POLICE and Peace Love protocols, great names. I admit I'm still biased toward using ice for acute injuries. I told you I was old. Assistive devices, This is the optimum loading from the police and peace love protocols. Suggest using a cane, crutches, or a walker to reduce stress on those knee joints. The rule of thumb with the cane is that if it's the right knee, then you put the cane in the left hand. For crutches, they give more support than the cane, and for long-term use, I prefer the use of forearm or elbow crutches, also called Canadian or Luftstand crutches. For the walker, this gives more support and stability than crutches, and you have some choices: 4 wheels, 2 wheels, going to no wheels, the so-called Zimmer frame. An ACE bandage tensor wrap is a cheap, easy way to support the knee joints. There are oodles of different ways to wrap a knee, but my best tip here is if it's too tight, take it off, try again, and your patient needs to compress the support around the knee joint line, so just at the level inferior pole of patella. Relative rest, explain the importance of modifying activities. This is where a lot of patients go wrong. Avoid that irritating activities that give them pain. I keep saying don't make things worse. Tell your patients to find that balance between rest and pain-free movement. Don't be super worried about stiffness or weakness from too much rest. Get your patients to rest. Get them out of pain. Then you can recover motion and strength later. Start with pain relief. Start with rest. Choose wisely, my friend. Passive modalities. I acknowledge that patients request passive modalities such as laser, TENS, ultrasound, especially if they've had these treatments before. Most patients love their passive modalities. It's like a relaxing spa treatment. Similarly, I'm not a fan of manual therapy techniques like soft tissue mobilization or joint mobilizations to reduce pain and stiffness. Use your time to teach patients to take care of themselves. But if you're going to use manual therapy for pain relief, be sure that it's a pain-free approach. Don't make things worse. These passive modalities may offer temporary pain relief for your patients, but they're not a long-term solution. Emphasize the importance of active strategies like home exercises and a moderate lifestyle for sustainable pain management. This is my bias towards actively involving the patient in their recovery. I've talked about this before in one of my videos. Pain-free exercises. Stress the importance of the no pain rule, allowing for mild soreness, but avoiding exercises that increase pain. Focus on gentle range of motion to maintain flexibility and reduce stiffness without exacerbating their pain. Seated active straight leg raise with dorsiflexion. This exercise helps improve knee extension while engaging the ankle joint. It is also a nerve floss glide exercise. It's back, it's hip, it's knee, it's ankle, it's everything. If you're only giving your patient one exercise during this pain management phase, this is it. Quad sets. This simple exercise activates the quad muscle without putting a lot of stress through the knee joint. Hamstring stretches. Gentle hamstring stretches can help improve flexibility and reduce that tightness in the back of the thigh. Looking above and below, ankle pumps and seated hip rotation log rolls. From this first stage of pain management, we go to the second stage, which is recovery of motion. Section 2, moving on up. Recovery of motion for the knee OA patient with education, manual therapy, and exercise. Recovery of motion for the OA knee has 3 sides: education, manual therapy, and pain-free home exercises. Always the home pain-free exercises. Education empowers the patient to take care of themselves. Use heat to relax the tissues. Use pain-free exercises to gradually improve knee range of motion. Set realistic expectations, aiming for 5 to 10 degrees of improvement in range of motion every 4 to 6 weeks. Encourage your patient to be as active as comfortable. Use the cane, the crutches, the walker if needed. Use an ACE tensor bandage for support if needed. Manual therapy. Physios love to crank on those stiff joints. But whoa, hold on there, champ. Remember, don't make things worse. Plus, some gentle traction usually helps. See my stiff knee video here for more details. Pain-free home exercises progress from active range of motion to static stretches to dynamic movements. Prioritize regaining full knee extension first, as this is essential for standing and walking. Standing lunge stretch, progressing to step standing lunge stretch. This is a closed kinetic chain exercise. Whoop, whoop, closed kinetic chain. This is the front knee into flexion and the back knee into extension. It's a hip, knee, ankle exercise. If you're only giving one exercise to recover range of motion, this is it. There are tons of other exercises for knee extension. These are some examples. And there are tons of other exercises for knee flexion, like these ones here. So choose exercises based on your patient's needs and abilities. See my book for more options. Once your patient has good knee flexion and extension motion, consider a dynamic warm-up movement prep program. This is the zombie kick exercises. This is butt kicks. Those specifically address knee extension and flexion. But I'd also add hip abduction swings. This is another sneaky way to keep the hamstrings moving while keeping the hips moving. And the hip rotation hacky sack exercise, like I said, to keep the hips moving. These are also crafty ways to get your patients to do a dynamic single leg balance exercise. So win-win for pain-free exercises. The other widgets physios use to improve range of motions are probably useless, or I should say unclear clinical evidence. So I don't recommend these. Static splinting or braces to maintain or improve motion. This is typically a long leg immobilizer brace. I've also seen patients kept in a kneeling scooter just to keep the knee flexed. Dynamic splints have a different brand names depending on where you are, but they're hit and miss for improving range of motion. CPM machines, these constant passive range of motion machines, they used to be quite popular in the 80s, but they've fallen out of fashion because it's not clear if they actually improve patient motion. From this second stage of recovery of motion, we go to the third stage, which is strength, balance, and mobility. Section 3, building function and preventing falls. Strength, balance, mobility for the OA knee with education, exercise, and challenges. Strength, balance, and mobility for the OA knee has three sides: education, pain-free home exercises, and functional mobility progressions. Education empowers the patient to take care of themselves. Have you heard me say that before? Encourage your patients to be as active as comfortable. Use the cane, crutches, walker as needed. Use that ACE tensor wrap bandage to support the joint as needed. Do not push your patients away from their little helpers. Keep them moving. Your patient is better off walking with a cane rather than struggling to walk without a cane. I see my neighbor struggling without her cane, and I want to yell at her, use your darn cane. Fall prevention is the goal. Talk to your patients and their family about home safety. Address potential hazards at home like rugs, cords, uneven surfaces. Are they in decent non-slip shoes? I'm not a fan of socks on smooth floors. I do like the grippy socks. Researching this video, I was reminded that lots of our older patients are taking multiple medications, and those medications contribute to them falling. But as the physio, we have to let the family doctor take the lead on reviewing those medications. So I've been sneaky by telling families to discuss the medications with the family doctor and leave me out of it. Pain-free home exercises. Our patients need closed kinetic chain multi-joint exercises. These progressions are in my book. And my pictures, my knee, OA, oh my, this is all about me. Not really. Start with strengthening. Mini squats with calf raises, mini lunges. Progress to static single leg balancing. Remember to start on 2 feet, progressing to 1 foot, 1 toe, progressing to single leg standing. I like the single leg balance with forward reach. I like the Statue of Liberty exercise, which is a diagonal reaching exercise with a mini squat. Progress to dynamic walking balance exercises. Here I like multi-directional lunges, walking on heels, walking on toes, walking backwards, walking with eyes open, walking with eyes closed. Functional mobility progressions. Like I said before, don't push patients away from their assistive devices, but rather push them to be as active as they are comfortable. Safety first. Emphasize those fall prevention strategies we talked about. Some functional exercise progressions: foot taps to step-ups, sit to stand with progressively less arm support, stair climbing, being sure to use the railing. In the clinic, we can introduce unstable surfaces like foam mats or the Bosu ball. Some patients like home or community-based mind-body challenges like Tai Chi, yoga, or some other kind of fitness exercise class. From this third stage of strength, balance, and mobility, we usually discharge to a home program and we're done. But wait, we need that little extra. We need that dash of pizzazz. We need the bonus section. Bonus section: what lies beyond physiotherapy for your OA knee patient? As physios, we're like Batman of healthcare. We try to do everything on our own. But even Batman had a helper. He had Robin. And don't forget about the butler, Alfred. Sometimes it really does take a village. Now I know what you're thinking, but But wait, isn't this stepping outside my scope of practice? Yes, yes, we must always stay within our scope of practice. Yet here we are talking about things we're not supposed to talk about as physiotherapists. I have 4 key areas that can help our patients with OA beyond the physio clinic. Lifestyle. Your patient can lose weight and take supplements. Glucosamine chondroitin is probably the most mainstream supplement, but not if they have a shellfish allergy, and they need to be on it for about 3 months to see the benefit. There's also turmeric, fish oil, and vitamin D. Medications. Ask your doctor or pharmacist about over-the-counter pain relievers that can help them with mild to moderate aches and pains. Some of these are oral, some of them are creams and gels. These can be progressed to stronger prescription medications as the doctor thinks appropriate. Even these over-the-counter medications can interact with other prescriptions or the patient's liver and kidneys if they're taking them for a while. So get the doctor involved. That's the safest way forward for your patient. Injections. For the knee, it's either corticosteroid for inflammation or high hyaluronic acid for mild to moderate osteoarthritis. Stem cell therapy and platelet-rich plasmin, the PRP injections, are controversial from a research point of view, but they can be great moneymakers for the doctors. Surgery. For the knee, this is either an arthroscopy for cartilage repair or loose body removal, or a full knee replacement, total joint replacement. Let the surgeons talk to your patients about those surgery options. Remember, we have a scope of practice. But one of the orthodox that I worked with would only consider a joint replacement if the patient came into his office using a gait device. He thought if the patient's hip or knee wasn't bothering them enough to make them use a cane, crutches, or a walker, they weren't functionally impaired enough to get that orthoplastic joint replacement surgery. You know what's not on this list? Acupuncture, massage, shoe orthotics, chiropractic manipulations. Are they useful? I don't know. We get into the consumer marketplace of healthcare and everyone wants your money. So caveat emptor, buyer beware. Part of writing this YouTube script was looking at how I approach my healthcare. After 30 years as a physio, I have my simplified diagnosis and a treatment approach. The other part was looking at how I'm taking care of my own health and my own needs. This is what is letting me live an active lifestyle. I find road races, the running marathons, half marathons, too boring, so I do the off-road, obstacle course, mud runs. I'm not super buff or active, but I'm doing all right. So when somebody asks me how I'm taking care of my 56-year-old knees, I'll tell them they have to watch this video. I know some of these points are controversial, like YouTube experts giving advice at all. Or should physios be talking to their patients about things outside their scope of practice? Even using ice is controversial nowadays. But when you're sitting in front of your patient, you need to come up with some advice. You need to help your patients. That's why we're here. And that's why I made this video. Let me know what your best advice for knee osteoarthritis is, because apes stronger together. My 2 books are now available at Amazon. What They Don't Teach You About Documentation in Physiotherapy School, a short how-to manual for successful daily note templates, and From Injury to Recovery Through Exercise, simple functional exercise progressions for physiotherapists to restore lifting, standing, walking. Thank you for your support. A super cool video is ready for you right here, and join our community of subscribers to stay ahead of the curve. Thank you.